Hi, and welcome to the July 2026 DermSurgery Digest podcast. I am the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Spotlight podcast focused on Mohs, cancer, and reconstruction, we have Kyle Lauck doing the in-depth article summaries of key articles, and Ally-Khan Somani as a senior expert editor with commentaries. Please don't forget that we continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic-focused on histopathologic content relevant to dermatologic surgery. Thank you for listening and have a happy surgery day.
Hi there, and welcome to the DermSurgery Digest podcast. My name is Kyle Lauck. I'm the current Mohs Fellow at Cooper Hospital, Rowan University, and today I'm joined by friend of the podcast, Dr. Ally-Khan Somani, MD, PhD. Dr. Somani, thank you so much for joining us again. Before we jump in, would you mind introducing yourself to our listeners?
Sure. So as you mentioned, Kyle, I'm Dr. Ally-Khan Somani. I was the founder and former director of the Mohs Fellowship at Indiana University. I'm fellowship trained and I'm currently in Illinois, Chicago. I also do private practice as academic teaching at Cook County Hospital. And I'm honored to be here today with you, Kyle.
Amazing. All right. Today, we are discussing the selected articles from the July 2026 issue of DermSurgery with a focus on dermatologic oncology and surgery. For this spotlight episode, we were going to discuss the featured articles for this July issue. To begin, we're going to start with increasing Mohs micrographic surgery utilization in darker skin phenotypes from 2011 to 2022 with Surya Veerabagu and Mackenzie Werner as the first author and senior authors, respectively. Skin cancer incidence is rising, but national treatment trends across skin phenotypes have not been well compared to date. In this retrospective claims-based cohort study, the authors analyzed Optum Informatics data from 2011 through 2022, including more than 1.6 million adults and 4.18 million skin cancer treatments, comparing Mohs micrographic surgery, wide local excision, and destructive treatments in patients categorized into lighter and darker skin phenotypes using available race and ethnicity data. In results, Mohs utilization increased in both groups by 53.9% in darker phenotypes and 46.7% in lighter skin phenotypes, while wide local excision and destruction treatments declined in their use. The authors conclude that Mohs use has expanded substantially across skin phenotypes, with treatment patterns showing more similarities than differences, while also acknowledging the limitations of claims-based databases as proxies for actual skin phenotypes and clinical appropriateness. Now, Dr. Somani, the study showed that Mohs utilization patterns are rising in both darker and lighter skin phenotypes. I was wondering where you think that trend might be coming from, places like maybe improving patient access or referral patterns. What were your thoughts with that?
Yeah, so this was an interesting study considering that, when I was a resident and going through training, we only focused on light skin, right? Fitzpatrick's skin type 1 to 3. We never really focused on darker patients and considered them as being at high risk for skin cancers. So I think that the education towards that has changed fundamentally. And I think that more of the trainees that were coming out, most of the Mohs surgeons that are coming out now truly recognize that these patients also are at a high risk for skin cancers. So I think the answer to your question is probably multifactorial. I think expanded, using Mohs AUC criteria definitely has helped identify patients at risk. But you have to understand that, based on the study, you saw that most of these patients were presenting with larger burden of tumor, larger sizes, high risk. So really, we're really playing catch up when we're catching these patients maybe at a later stage in their trajectory of being diagnosed from biopsy time to being appropriately referred. One caveat of this study is I don't think it really answers the question about equity, because it's mostly about utilization, because the people accessing this, and this database obviously is patients who have access to insurance and ACA, ACA era, in the ACA era. So I think that the denominator has grown in this group, but that doesn't necessarily equate to, that we're detecting the equity gap between these patients.
Yeah, that's a really great point. Jumping a little over to management, when you have these patients that don't have the classical Fitzpatrick 1 or 2 skin type that we run into so often, are there any specific counseling or reconstructive considerations that you think about when you have darker skin phenotypes, things like dyspigmentation or different risks of hypertrophic scarring?
Yeah. Again, this is a very important question. I think it doesn't matter the skin type, at least in my practice. I think the most important thing is preparing the patient and having them appreciate and have realistic expectations. So you have to explain all side effects. Hypertrophic scar can even occur in lighter skin patients. So getting a good history, knowing whether they're prone to developing these scars, and dyschromia is a really big part of this. And in fact, the paper mentions that a lot of the litigations around bad satisfaction of scars tends to be centered around dyschromia, post-inflammatory hyperpigmentation. So I think um, explaining to patients the risk and allowing them to appreciate that is very important. One of the things in the study, they mentioned that linear scars did better, like linear repairs compared to flaps and grafts. And again, I think that um, the expectations for patients when they see a linear closure, it's really easy for them to appreciate that in general. I think in both groups. I think flaps initially don't look right because if you have a transposition flap, they look funny, they look out of shape. But once the scars settle down, it looks better. So I think setting up, realistic expectations, walking the patient through the trajectory of their healing plays an important part. So I don't really think I changed that much my approach to repairing patients. Maybe I will, the only thing that will be much more focused on would be explanation of the potential complications and being ready there to hold their hands. And if they do get hypertrophic scarring, to use other adjuncts like intralesional Kenalog, silicone sheets. So I think you just have to know that these options are available and your patient knows that you're going to be there for them when these things occur.
Yeah, I think it always serves us in the long run to take the time up front to
I
educate
agree.
patients. Yeah. So, that looking at patient expectations, I think that's a great transition over to our next article. Um, so we're going to move on to our second article, which is patient satisfaction with outcomes of Mohs micrographic surgery, a prospective cohort study using the Oxford Skin Cancer Treatment Scale by Amanda Ferrante as first author and Fazia Mikowski-McNeely as senior author. So
Yeah.
Mohs surgery is generally associated with high patient satisfaction, but satisfaction is multidimensional and may be influenced by the patient tumor and reconstruction, as well as many other factors. In this prospective cohort study, 106 adults treated by three Mohs surgeons completed the Oxford Skin Cancer Treatment Scale immediately after surgery and again at 1 and 4 week time points. This 12-question survey separately evaluates satisfaction with scar appearance, the decision to undergo Mohs, the treatment experience, and concerns about recurrence or spread of tumor. Overall, satisfaction remained high and did not change significantly during the 4 week follow-up period. Linear closure was the most consistent procedural predictor of high satisfaction, including better overall scores, aesthetic, and treatment experience scores. Interestingly, diabetes and immunosuppression were associated with a higher total satisfaction. The authors concluded that understanding these relationships may help surgeons to set expectations, individualize counseling, and provide more patient-centered Mohs care. I think jumping from your prior point, it was really interesting to see here how linear excision versus flaps played a role. And, I was wondering what your thoughts on that were in this study.
Yeah, so this study was an interesting study. I thought you would probably ask me about the fact that what I found interesting was that diabetes and immunosuppression had the higher overall satisfaction, but we can talk about that in a little while. Um, I think that again, linear studies normally are done by most surgeons. I always say the KISS rule, right? Keep it simple, surgeon. I say keep it simple, Somani. But the whole idea is that if you can close something linearly, usually they're smaller defects. They're positioned in a place where there's laxity, easy to close. So I think that obviously makes it easy for patients to appreciate, and the satisfaction is always higher than a more complicated closure. Um, So I think just as I said previously, I think that that makes it really simple for patients. But also you have to recognize that this study, the time points were very short. 1 week and 4 weeks. And you know, and I know, and most surgeons know that, scars don't mature that quickly. 15 months to be completely healed, about 6 months, 3 to 6 months, minimum 6 months, in my opinion, you get a real good appreciation of the scar remodeling and the healing, because our sutures last 6 to 8 months also. So there's a lot of inflammatory stuff happening beneath the skin, and depending on the patient, depending on how they heal, that timeline shifts, obviously, plus or minus. So I think the study, that's why I don't think it found any difference between 1 and 4 weeks, in my opinion. So I think it should have been longer time point. Um,
That would have been I think that would have been a good addition to the study because you're exactly right. These flaps have to be evaluated long term. Jumping to these other variables, I think that that was perhaps the most surprising part of the study was, these like medical comorbidities that seemed to indicate a higher degree of satisfaction. The authors had some theories about why that might be happening, but I was wondering what you thought about it.
Yeah, you know what? So I've as being at when I was at Indiana University, I saw a lot of patients who were immunosuppressed, a lot of transplant patients. One thing about these patients is that they're resilient patients. They've been through so much. They've been in the healthcare system, in and out, and they were their organ transplantation and all the meds they're surviving on this new organs. So for them, a skin cancer to them in their mind is a very small thing. It's an easily treatable thing. Unless they have tons of them, then you get biopsy burnout, and that's another issue we can talk about. But the whole issue here is that, and a lot of them actually, even though the study didn't show this, which I was surprised, is a lot of them have had Mohs or have had excisions uh, in the past. So they're kind of aware of how healing occurs. They're kind of they're no longer novices when it comes to this treatment. So they have that inherent appreciation that this will be a 1 day thing, cancer will come out, and it's curative, which they don't really get with their other morbidities, like, the long-term diabetes, the transplant, seeing doctors and drugs. They know that once the tumor is taken care of, that page is closed for them, and they're just following up for any kind of recurrences. And I think that sits well with them, and I think that's why they are more satisfied and compared to people who are not as well.
That's a really good point. I think, another methodological consideration is if we could stratify into patients who were first-time Mohs patients versus those who had multiple surgeries in the past, I would imagine that, yeah, that hypothesis would be proven correct, that those people probably have a little less anxiety.
Yeah.
Um, so I think this was overall, I mean, a good study that demonstrated people do feel pretty good about their Mohs surgery, and that it was interesting to see these patients that maybe have a higher immersion in the world of medicine maybe have a little less anxiety about it.
Hmm.
Um,
Hmm.
so,
Yeah, Kyle, yeah, we did an interesting study a while back,
mhm,
and with one of my fellows as well as some of my medical students and residents, and we did a study. We looked at, I think it was about 145 patients, and what we did is our study was very different. We did anxiety measurement using a VAS scale. Um, we did it before, right as the nurse met the patient, before the doctor came in, after the doctor left, after the anesthetic, after the first layer, before the first layer. We captured almost all the time points. And the study was interesting because we got some interesting data. One thing we found out is that pre-consultation didn't make a huge difference. Having Mohs done before really in our study didn't really make a huge difference. But what did make a difference with anxiety was younger age,
mhm.
female, so women, young women, and anyone who was previously diagnosed with an anxiety disorder, like healthcare professional diagnosed. So if they had an inherent anxiety condition, that obviously elevated their anxiety to the procedure. And one thing we also found is that obviously more layers led to more anxiety,
Yeah.
which makes sense. And interestingly enough, the study that looked at satisfaction that was published
Mhm.
also showed that more layers leads to more less satisfaction. So there must be a link here between anxiety and satisfaction, which hasn't been looked at, which would be an interesting measurement, a good metric to look at of how that correlates.
That would be a great study to do. So maybe somebody out there can look into this. Next, we're going to move on to from patient-reported outcomes to a core safety issue in derm surgery, and that is correct site identification.
As a DermSurgery Digest listener, here is some quick partner information. Mark your calendars out of office this November 5th through 8th. Learn why from our 2026 ASDS Annual Meeting Workgroup Chair.
Hi, I'm Nazanin Sadie, and I wanted to encourage you all to attend the ASDS annual meeting in San Diego this November. It's going to include all of the hottest topics in dermatologic surgery, spanning from cosmetic dermatology to Mohs surgery to reconstruction. We're going to have interesting topics like the latest in GLP-1, wellness, menopause, regenerative medicine, and from experts from around the world. I hope to see you all in San Diego.
To learn more and register today, visit asds.net/annual meeting. The future of dermatologic surgery starts here. And now, let's get back to the conversation.
So, looking at our next article, we are turning to Optimization and Prevention of Error in Surgical Site Identification by Shane McTee as first author and Joshua Lane as senior author, along with an accompanying commentary by Aaron Tisak as first author and Rajiv Najawan as senior author. Wrong site surgery is a preventable but persistent risk in dermatologic surgery, particularly when shaved biopsies or when biopsies of any kind have healed over. Patients that have multiple lesions and care which involves several referral systems are also risk factors. This review searched PubMed and Google Scholar for dermatologic surgery studies published from 2014 to 2025, including 41 directly relevant articles. The authors found that no one single intervention reliably eliminated risk. Prevention depends upon layered redundant safeguards, such as standardized documentation, biopsy site photography, precise anatomic measurements, adjunctive tools, structured team verification, and active patient participation. The commentary by Drs. Tisak and Najawan highlights standardized photography as a practical safeguard and emphasizes that if any uncertainty remains, the safest action is to pause, clarify, and when needed, reassess or rebiopsy before proceeding with surgery. Dr. Somani, the central message of this review seems to be that safety is strongest when multiple safeguards work together as one. And in your practice, are there any core bundles of protections that we should think about completing before we take the first layer? What are your thoughts on that?
Yeah, so I read the commentary as well as the paper, and I think that both have identified everything that we all appreciate and think is important. So I think these are good papers. In my practice, obviously every patient has to have a photo, and we can talk about the photo technique as well because that also matters. There was a really interesting paper called Biopsy 123, and I think it was by Harrington, and I don't know if it was in derm surgery or not, but I can provide that reference or we can look it up. It basically said when a patient gets a biopsy, and I tell my patients too when I see them, I go, most of them have a smartphone. So I say, when you're having your biopsy, give your phone to the nurse or the person there and have one other person, so one is for another person, to take a picture. And the picture should be two pictures, so the two. And there should be one nearby so that we can at least see the borders of the tumor. And the other one should be far away, that there's two anatomical positioning so that you can triangulate. So you're not just focusing on that one area. And three, you can take another picture that, is zoomed in or from another angle, but definitely 1, 2, and 3. And I tell my patients to do that. So this way there's no HIPAA issues. They have it on their phone. But what we're doing lately is I use a platform called Spruce. It allows me to communicate with my patients by HIPAA using a phone number that matches the clinic number. It's HIPAA compliant, and patients can send photos through the app. And so my scheduler has access to it as well. So when she gets a referral, if a photo is missing or not clear, we quickly ask the patient before the day of the surgery to send us the photo so we can properly triage the patient as well. So I think photos are important, and I think that the way of a selfie is not as good because patients have to contort themselves to take a picture. They don't really appreciate what we need. And so I think that another healthcare professional, a nurse, an MA in the room taking it with their phone is a good way. Um, in worse situations, when you can't identify a site, it's better to just delay the surgery, in my opinion, and that's what I do. And I send it back to the referral physician. And if it's in the same practice, I will stop and I will let the patient go downstairs, or I'll call the doctor that did the biopsy to come up quickly to the clinic and mark it. And if they're not sure, then a biopsy obviously confirms the area. And if we get a scar, then we will, clinically make it reasonable to follow the site for seeing if there's any clinical recurrence. The other thing that I didn't mention here is that when I had my fellow Abraham Abdulhaq, he had this idea of using UV light, which we published in DermSurgery, 365 nanometer light, which really helps, especially if the scar is very well healed and you can't identify the erythema is gone. You can shine the light, and it's not used to identify a primary site, but if you know where the location is, you want to confirm it. It allows you to see because the scar loses a lot of the follicular accentuation, and Cutibacterium acnes is missing from there, so that it fluoresces differently. And I think now the new dermatoscopes actually have the ability to have UV light in it. A Woods lamp is built in, which is amazing. So that's another potential adjunct to identifying a correct biopsy site for us.
Yeah, no, that I may have to steal that spruce app from you because that has been a big issue, and I
Yeah, you
think
know
that
what? It's amazing. And also you can create wound care. So all my wound care pictures, I get them at
Mhm.
1 week, I get them at 6 weeks, and anytime in between, and I can direct them whether they need to come in. And since I use absorbable sutures, it makes the clinic flow better, and patient satisfaction is through the roof because you're giving them concierge care, and they know they can reach you anytime if there's an issue.
Yeah, that's great. That's amazing. I'm gonna have to use that. Okay. So this was a nice bridge using safety systems over to another practice level issue in our next article, how dermatologic surgery can reduce wastefulness. So our final article for this spotlight episode is Reducing Waste in Dermatologic Surgery, an Evidence-Based Review of Sustainability Strategies by primary author, or first author, Vixie Silva, and senior author, Stan Tolkachev. Dermatologic surgery produces substantial waste through disposable instruments, protective equipment, packaging procedure packs, and postoperative supplies, yet specialty-specific sustainability guidance remains limited. In this evidence-based review, the authors searched PubMed for studies published from 2000 through February 2025 and graded the available evidence using Oxford and Grade frameworks. They identified 28 strategies across preoperative, intraoperative, and postoperative care, with 15 supported by level 1 or level 2 evidence. Practice strategies included using non-sterile gloves when appropriate, reducing unnecessary sterile barriers, considering reusable drapes and instruments, using low dead space syringes, selecting longer acting anesthetics when they may reduce return visits, using absorbable or continuous sutures in select cases, and simplifying postoperative dressings. The authors conclude that dermatologic surgeons can meaningfully reduce environmental impact while maintaining patient safety, procedural effectiveness, and high quality care. Uh, so, Dr. Somani, I wanted to get into some of the recommendations that they made. So, evidence suggests that non-sterile gloves and reduced sterile barriers can lower waste without increasing infection in some select procedures. In your practice, how do you decide when to use clean technique versus when you're using fully sterile approaches? I'm curious how you do things.
So coming from an academic practice, being the director of a Mohs fellowship at a university setting, rules were very strict there, obviously, compared to now being in private practice. I've had to do a real paradigm shift on how I think about sterility. Obviously, in a university setting, everything is done sterile except for the layer part, which is clean. And then when I came to private practice, we also use non-sterile gloves for the closures. And I have to admit, I'm still kind of old school. I still use for bigger flaps. I just feel I like the feel of the gloves, but really I've done both and I've not seen any SSIs with my cases. And in fact, there's obviously lots of studies that show that the infection rates are comparable whether you use, whether you use sterile gloves or non-sterile gloves, it doesn't really change. However, what does change is patient morbidity. If you have immunosuppressed patients, or they have larger flaps, or if they get complications like hematoma. But this is, I think, unrelated to the sterility of the procedure. So that's one thing. So I use basically regular gloves now. I think it does cut down the cost. And I think a lot of these measures that affect our environment and our, the things that we're concerned about, are also cost saving. And I think most private practice are already doing a lot of these things. It's the bigger institutions like hospitals and academic centers. And in fact, I was surprised at the VA, for example, they are throwing away the drapes, and they're not doing relaundry. There's a lot of wastage, and I think that a paradigm shift is needed in our field, especially in these larger institutions where they equate what we do in outpatient settings to what they do in the OR. And I think that those rules are kind of migrated to us as well if we are in a hospital setting. But I really agree that this paper really points out a lot of the areas we can focus on to reduce wastage and help our environment.
Yeah, I think that's a really good point about that paradigm between private practices and academic institutions, because I think most of us trained in a place, I myself, where we're using a lot of sterile gloves, and there are a lot of things that are done that are very meticulous, and in going out into the private world, things are different, and so it is interesting to see how it shifts. I'm curious, as you kind of have to introduce changes, or if you're trying to begin the process of maybe making things less wasteful. I know that, certain staff or team members can kind of wonder like why you're doing this, and they may not entirely understand. I'm curious how you might introduce this into your practice, or like what you can communicate to staff members that may reinforce this evidence-based and quality-based metric that you're trying to pursue.
Yeah, that's a really good point because you could see how it would look like we're cutting corners or making things cheaper than they should be and compromising patient safety and health, their health. I think you just have to go with the facts. We can just tell them that, we use non-sterile gloves because there's studies that show 12,000 procedures confirm them that they're same and safe, and they're meaningful, and they use less plastic waste. So we're not only not changing how we take care of our patients, they're still taken care of the best way, but we've now also meaningfully helped our planet by reducing waste. So I think that that's an easy buy for everyone. But as long as we say that there's studies, and there are evidence-based studies that show that there's no compromise to patient safety.
Yeah, that's a great point. So I think that's a good place to close off. So Dr. Somani, thank you so much for this thoughtful discussion, for all these practical pearls. I am definitely going to download the Spruce app. And yeah, thank you for coming on the podcast.
Thank you, Kyle. It was a pleasure.
All right. Listeners can hear additional commentary on the remaining July issue articles in our Rapid Pearls episode on the same podcast platform, where you can visit ascs.net/DermSurgery Digest for additional journal podcast content. So everybody have a great surgery day.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.